Hey, Antonio. Oh, hey, guys.
How's it going? Hey, Julie.
Hey. Did you get any word on what's going on with that space, with that touchdown area?
I mean, that's Rahul's spot. The problem is that computer got taken away because it was no longer like IT compliant or something. So
Okay.
Well, I mean, most of the time I bring my own computer, I feel like places anyway. Is there a monitor?
Yeah, I'm the same way. If I remember, that computer was sort
we
of
need a
slow
better
anyway.
monitor though than that.
Yeah. I mean, if there's a way to just get a better monitor, that might be enough. You know, like.
Yeah, because the computer itself wasn't that great, I'll tell you that.
Yeah, I figured.
It's no Mac. There was no Mac.
Yeah, Antonio, it's no Mac.
Julie got some nice shout outs for her paper on assessing for gastric contents.
I was like
It's
so
a classic.
I
It's a
was
classic.
so
Awesome.
honored.
It's a classic. That's why I only wait 30 minutes for NPO status. Based on
The story, like the anecdote of the child whose gastric contents increased after like 6 hours,
Yeah.
also like
Don't wait.
really influences me. And Matt Moeki, who he did the same thing, and he found that like some increased also.
All right, this looks good. This is good. You have to join us next time. This is our second time doing this in the conference. There's a new TV monitor. The resolution is much better. Audio works. It's great.
Yeah, good stuff.
Remember we were gonna do it in the library because it was so crappy here?
Oh yeah. I can't wait to do Past the Pointer in person again. What is PRPEC? What's the R, regional?
Where? I don't think so.
What's the R?
Where are you talking about, Julie? For where?
It's like PEPEC now, right? Didn't he change it?
It's PEPEC now?
Yeah.
I missed that.
I missed it too.
I was not aware.
I think Antonio knew. How's this look?
Looks great.
Okay, and then let's try how does this look?
Also looks great.
Cool.
Yeah.
How's everything going?
Nicely, no choppiness. Looks good.
Nice. If it becomes choppy, can you just let me know and I'll turn off my video?
Yeah.
Cool.
Yeah.
It's sharing this one, right? It's sharing the screen.
Yeah, we see your cover screen. Your title slide.
Great. How's it going, Rahul?
Good. Yeah, thanks for responding to that text a couple days ago. At some point, yeah, I'll talk to you later on. I want to make sure I'm like contributing. I feel like I'm not contributing a lot to like the adult section right now. It's like,
well, yeah, I mean, you cannot at all compare yourself to Suwando. He's been doing this
he's
for
got
4
years of like they do ultrasound all the time every day.
And like you can imagine, he told them when I was a fellow that he wanted to do the POCUS fellowship. So he's been working with them like
yeah. I'm not trying to compare myself to him either. Like he's also like a really nice guy. So he's like it's not like it's not like that. It's more of I just want to make sure I'm like
doing the right
giving
thing.
them some benefit. Like
they're supposed to give you benefit.
No, Rahul, you're like so valuable to everyone's teams and to image review there. Like they actually like, so I guess what you were saying is that he's running image review sometimes.
He just like, so what has happened, not the last week, but like the first couple of weeks, granted, I've only done this for like 3 or 4 weeks now, but like, I feel like half of the time, one of the one of the core faculty staff that have been there for a while, like sort of do the first hour of image review, and then they have to like leave, and so Dave does like the second half of it.
Oh yeah. So
Cool.
it's circumstantial because when I was hey, welcome. When I was the POCUS fellow, there were first of all 3 fellows, one of whom was there for the, you know, the second year in a row. And image review was always back to back the POCUS faculty. And then like occasionally, you know, they would have to leave, like there would be an hour gap in the 4 hours of image review. And like, and then like the 3 of us would take over together sort of, or like, or James Daly, who was the second year, would take over. But like, there was no expectation of like, you know, that the first year fellows would run it, especially this early on.
Okay, that's helpful. Thanks.
Yeah, let me know. Also, you know, so like again, Suwando was like knows them and has been there, and like, so it's a totally different situation. But when I was there, you know, Vryhoff was my co-fellow, like my adult counterpart, and it was like good to have that camaraderie during conference when we're like, I don't know the Nyquist limit. Do you know the Nyquist limit? Like, what is the, you know, tricuspid rigor that velocity number? And so it's really nice to have that. So I can imagine it's a little bit like isolating to not have that, but feel free to text me anytime you want, and I'll be your support person.
Hey, thanks, Julie.
Yeah.
Much appreciated.
Wait, so Antonio, what does the R in PEPEC stand for?
Puerto Rican point of care educational collective.
Okay, sounds good.
It's a typo, I'm sorry. I sent an email out, but everybody's welcome to join us. But I typed in PR pack instead of PEPEC.
I see.
Is Henry moderating?
I think so.
That way I don't have to pay attention to the chat. Oh, we're early still. It's only 5. Okay. Yeah.
We got time.
Yeah.
Myself.
Just remember, we're on a hot mic. We should probably mute at some point.
Is there like a
hot mic?
Yeah. This is wireless. Is this wireless?
Oh yeah, it might be actually. Good call. And the
Is the mouse also?
the mouse too.
So this patient that I had with tetralogy of Fallot the other night, so I realized also that so he has a melody valve,
Oh yeah.
and you know he's at risk for endocarditis. He came in with a fever, you know, and even though he had like his X-ray really looked like it was aspiration. It was like slam dunk right middle lobe, probably aspiration pneumonia. He's at risk for it, but there's always a risk when he has a fever for endocarditis. And I was talking to Erin Faraday because, you know, we don't really have a way on focus to take a look at the melody valve. Like that's not part of the standard, you know, focus protocol that we have. And I was asking her if there was a way that, you know, what they do to try to risk stratify. And she was saying like the pulmonary valve is just so anterior that's just really hard to see, and they're measuring the velocity through it. But yeah,
I think you gotta do like some weird subxiphoid view and turn in a certain direction to catch it, but
yeah,
it's definitely not like a super easy
no.
Anatomical structure to identify, especially if was that the kid that was really agitated and poorly cooperative too?
Yeah, he kept pushing me away. It was really hard to even get, I just want to assess function and assess, you know, a fusion. That's it. But yeah.
I want to start doing more arch, like
arch. super curricular.
I'm not sure. Did you do that in Echo Lab?
Yeah.
We should try to do that
Well, I asked them.
just for fun.
I asked them like if there would be any utility in the ED that they could think of, like, and they said probably not. I guess not.
Or like a core. Like,
Yeah,
I just don't
right.
know how to do it for. I don't know how to reliably capture it like anymore,
Right.
but we can certainly try. Yeah. So let's do that for fun.
Yeah. Yeah.
I don't know, you guys, I might end up just chatting with the with the three of you guys.
Sorry,
Are
I'm
we in the
Steven.
right-
I'm
are we
one
in
of
the right
the.
room?
There are worse things. I'm one of the first year fellows at Cohen Children's Hospital on Long
Oh,
Island.
cool.
Oh, hey,
So
Steve.
Our
Welcome.
tape review got canceled for today, and so they said, "Hey, if you're interested, like, there's this other thing going on with some people that are kind of
Yeah.
cool." So, all
Oh,
right.
yeah, we're kind of cool.
Yeah.
Yeah, we're on.
Thanks.
But I get that vibe.
So, okay, so you're one of the first year PEM fellows.
No, first year. Yes, I'm sorry, first year Penn fellows.
Cool. I really like the people there at Cohen's.
Me too, fortunately.
I just texted Henry. Hello.
He's coming on. Hey, Henry.
Ah, perfect.
Hey, how you doing, Julie? Everyone.
Hey, Matt.
All right, we're good.
Hey,
Thank
Matt.
you for presenting as always, Julie.
Oh, yeah, my pleasure. Thanks for having me.
We'll start at 1:05 so that way everyone can come in.
Sounds like a plan. Matt, we were talking again today about the gastric contents during sedation issue. Yeah, because we had a morning conference on sedation, and I was saying that
Have you done it at all since your project?
actually, I have a case in here that does involve gastric ultrasound, so I'm glad you're here because that anatomy is like so burned in my mind and like brings me back just like to see that anatomy, but doesn't have to do with sedation though. You'll see.
Yeah, I've yet to like touch it again. I just tell people like, oh, we can look. I'm like, they're full. They're full. Like, I don't need to like. There's no point in me doing this. Like, they're full.
Right, exactly.
A second
Yeah, I
manuscript.
looked. I found it. I saw what I needed to see.
Yeah, I still have a second manuscript. I need to like tweak and send in at some point from
Oh,
like a
nice.
separate half of that. I just don't care. It's like doing it for the sake of trying to get like one more notch on the ledger. And I'm just like,
Yeah.
I'm so many
What
other
are you
things.
working on now?
Oh God. I'm gonna be a site for the Tesaro's optic nerve study. And I'm doing some stuff I've got a lot of things where I'm like collaborating with folks right now. Not really driving heavily to anything myself. So that one, and then I'm working with like that P2 like research priorities thing. And then I also sort of got like, I emailed with like Aaron Chen after his one like optic lecture back in the fall,
Yeah.
and sent a bunch of like path that we had, and have kind of looped in on that, which largely the end of all those tells me that like, I just don't know ocular ultrasound, and probably nobody does, is my impression.
That was essentially my conclusion from his talk.
Yeah. He's like so much up here relative to what.
Yeah. What is Tesaro's study looking at? The optic nerve sheath diameter?
Trying to establish norms.
Yeah. Okay.
So, which I think would be super
the
helpful.
6
if we actually get. Hmm?
Okay. Is that the 6 kids study that you're doing for the normal or the
Yeah.
sheath diameter? Okay.
Yeah.
You know
And
any one that's coming out? Because I'm very interested.
Oh, like they only have, I think, 2 sites that have even started enrolling.
Okay.
So like, most people are still stuck. I just got through the red tape and I'm like, have like my data use and my IRB approved. So I think the sites are supposed to be done enrolling by like October of 2023. So
Oh,
don't hold your breath.
yeah. All right, fine.
Hey, Julie. What's up?
Hey, wait, I can't see.
It's Josh.
Josh, how's
How you
fellowship
guys
going?
doing? It's good. It's good so far.
Good.
Yeah. Yeah. All set up here in New York.
Nice.
It's cool to see that you're on this meeting as well as Antonio. I see him over there.
Hey,
Oh, yeah.
Josh,
Who's Antonio? Who are you with?
this is Dr. Shah, Dr. Rahul Shah.
You guys.
Oh,
Oh,
snap.
didn't-
Yeah. He came over from the other CCMC. And
Yeah.
he's an ultrasound fellow now, right?
Yep.
Awesome, man. How's it going?
Good. How are you, man?
Great.
We're
Good to see you
socially
guys, man.
distanced by 6 feet, but we have to wear masks indoors.
Oh, I see. All right.
Thanks for joining, Josh.
Of course. Gotta see what my other people are up to, you know what I'm saying?
Oh, Henry, what is the R in PEPEC? What is that new?
The what?
Isn't it? Did you write PRPEC? Did I?
No, PEPEC. If I did, I probably misspelled it. That was my mistake. So
It's a silent
Someone
R.
wrote a typo somewhere, and I've been racking my brain like, what did I miss? And I'm asking around.
no, that's probably my mistake when I'm writing emails in the middle of the night. So
Great. So I didn't miss anything. All right, should I get started?
yeah. So anyways, but thanks everyone for joining in. Today we're gonna have Dr. Leviter from Yale presenting. So thank you. And then I just wanted to remind everyone that we're gonna take a month break for August, for vacations, all that stuff, so I can celebrate my birthday month. So I need a whole month off for that. So we'll be picking back up in September 2nd, just so that way you guys not going to be bothered by my weekly emails. So, but without further ado, you go ahead, Julie, you can take over.
Thanks. So thanks everyone for joining. And as always, please, comment, write in the chat. I have my chat box open and I'll be responding to discussion because I'd love for this to be interactive. All right, so we are gonna start with a 9-year-old boy presenting with abdominal pain, emesis for one day. So interestingly, this kid with abdominal pain and emesis had tested COVID positive 7 days prior. And at that time, he had headache and fatigue. And then early yesterday morning, he started with periumbilical pain. And then it was just followed by vomiting all day and was unable to tolerate PO. And it's just been gradually getting worse. So he also has cough and fatigue, no more fevers. Or I'm sorry, I don't think he ever had fevers. But on arrival, his vitals were actually normal. He's statting 97%. And on exam, he has some decreased entry in the right middle lobe. And he also has some abdominal tenderness to palpation, particularly in the right lower quadrant and a little bit suprapubic. What's sort of on your differential right now?
I mean, with COVID, there are a lot of reports of kids coming in with API-like levels of pain and mesenteric adenitis.
Yeah. So that was something that I thought was really interesting, like for those two things to be that was related. But yeah, his abdominal ultrasound, I'll skip to the point, was negative, and he had no API. But then I took a look at his lungs, and this was our community hospital where I only had a butterfly available. So here's the right upper lobe. And for those of you who are not used to seeing these all the time, we have just pointing out so here's rib, lung, there's the pleura, and the A lines, rib. Okay. And then we start to see some of this coming down to the right middle lobe. So over here, some B lines starting to come into view, a little bit of pleural irregularities. And then this is coming down to the lower portion of the right lung field. So really a lot of pleural irregularity here, confluent B lines, and we have some lung shred sign. And here's another view of that. And feel free to add anything else that you, and then here we're just touching the diaphragm to see what's going on over there, if there's any effusion or consolidation. And here's our diaphragm coming into view. And above that, it looks to me like some kind of consolidation versus atelectasis. I mean, there's static air bronchograms there. Again, the shred sign. Anything else that anyone else wants to add? And with the history of COVID diagnosed a week ago, I know that there's a lot of reports and discussion about what COVID's going to look like on ultrasound and in kids. There's a lot of reports in adults for sure. And then in kids, not more like case reports that people I've seen have been putting out. But I'd love to hear what everyone else has been seeing. This is the chest X-ray. So it was read as patchy bilateral airspace opacities, suspicious for COVID pneumonia. And then I was talking about the case series. So this is a case series that some of our colleagues over at Columbia published, lung point of care ultrasound and pediatric COVID-19, a case series. And they also mentioned these bilateral abnormalities, including pleural line irregularities, scattered and coalescing B lines, consolidations, and pleural effusions. So I thought this was interesting. For sure, if I had seen this outside of the COVID pandemic, I would have said this is a slam dunk, just community acquired pneumonia based on those findings. But it's sort of interesting to me that that's also what we're finding in COVID pneumonia. And I'm curious in the group, how many of you would have also treated with antibiotics versus attributed that entirely to COVID pneumonia?
So I think you got to separate out your two statements. There's no reason to say that this isn't a slam dunk community acquired pneumonia.
Mhm.
It's just the thing that's out in the community is COVID.
Right,
And
exactly.
this is why, is it Florin's group that's doing the watch and wait for pneumonia right now? So many of these things are viral, and there's nothing on our X-ray or our ultrasound that helps us to differentiate bacterial versus viral.
Right.
So, I don't think anybody's wrong by calling that a real consolidation, not that sub-centimeter stuff that we see with bronchiolitis or, more typically with COVID. I mean, COVID was really just the adults discovering what we've seen with bronchiolitis for the last 10 years. But that's, a very focal, isolated consolidation. That's what we call pneumonia. The next step is whether or not that's something that needs to be treated with antibiotics or not.
Yeah, for me, there's inconsistencies with the concept of like the typical findings with COVID, right? You weren't alluding to, patchy bilateral findings unless I missed it, right, Julie?
Yeah, I actually didn't see that on the left side. It was really those right-sided focal findings.
Yeah. And then I know the guy out of Italy, I'm blanking on his name, but they were talking about the lighthouse sign, which I saw it once and was like all super excited about it. And then the patient ended up being COVID negative. But it's just the concept that you're constantly going to be catching the edge of, fluid-filled lung and air-filled lung. And
is that like another name for lung shred sign?
No, it was this kind of entity where they were saying like, because you're frequently catching literally, because there's so many different areas involved and subsequently so many areas not involved, that you're constantly catching kind of like the edge of the pneumonia or, of the fluid area. And
was that describing the subpleurals with the dense B lines coming down deep to that?
No, well, I don't want to say no, but basically he was alluding to the fact that if you stayed still with the respiration, you sort of got this like, it had this quality, how like a lighthouse kind of has a like a cosine, pattern to it as it swings around. Am I crazy? I don't know. That's what he was.
Yeah, but I think that was describing, because I've heard it called like the waterfall sign or
I've heard
No, this
that.
was something else, Adam.
the beehive sign. I don't know. There's so many different. I love our field because we make up so many names, but then it's hard to associate each other with each other.
The thing they were trying to describe, I think, was somewhat separate and
Okay.
more unique to COVID. But
I don't know, but was COVID? I look at all these ultrasounds and I don't see anything unique to COVID. I mean, you could put up 100. You know, we could do one of these studies. What should Marsha put out the one from UCLA with the lung ultrasound stuff? We could put up 100 lung ultrasounds with flu, RSV, and COVID, and ask people to identify which one is which, and you know, you will get zero correlation. I'd be willing to bet any amount of money on that.
no, I'm not disagreeing. And the one time I thought I saw it, it ended up not being COVID. So I clearly, so, but
Or
to me,
perhaps,
at
or
the very
perhaps
least, the classic thing they talk about is bilateral patchy findings, which you didn't have.
yeah.
Yeah.
It really was more focused in the right, like middle/lower lobe for me, but it was sort of interesting on chest X-ray. It was like bilateral patchy.
I mean, this is our big question, right? We see things on ultrasound that they don't see on plain radiographs. And so what's the right answer?
We got to
And the
start
right
doing
answer-
lung biopsies.
No, but we could do that. We could do Adam's idea, and we don't want to get stuck on this. I feel like we talk about this, at length, sort of with every conference, and it's an important topic to discuss. But we could totally just find across institution, lung pathology cases that are tied to either a PCR, or maybe we're lucky enough to have a blood culture or some sort of bacterial culture. And then just do that with video clips. It'd be retrospective, but you could have novices and you can have experts, and it wouldn't be that hard to decide. I think we should talk more offline about something like that. It would be pretty easy to do, and we could do it through PEPEC. We could do it through folks that participate, because we've had so many cases presented and so many conversations about this.
All
I
right.
nominate Julie and Antonio to lead that.
It was fine. We could do it.
All right.
We could do. Rahul might want to do it.
I nominate Rahul.
Yeah, we could totally do it.
All right.
I agree, Antonio. I think that would be pretty easy to do because we all have like pathology, and we just have to find whoever we deem is like I guess radiology, and then another PEPs. But I think that's a great plan.
Yeah. Great. Good ideas. Love this. All right. Next topic. We have a 13-year-old boy presenting with fever, weakness, shortness of breath, headache. This kid had been diagnosed with COVID a month ago, and he had been asymptomatic though. He's also 2 days prior to his current presentation had been hospitalized overnight for MIS-C. And at that time he presented with fever, sandpapery rash, diarrhea, poor PO. He got IVIG and Decadron and was discharged with a script for a steroid taper and aspirin. And the echo at that time was normal. So now it's 2 days later, he's having a fever to Tmax 104, weakness in his legs, and he's hypotensive to 70/30 with EMS. Here are his vitals. So blood pressure is 68/30. He is tachycardia to 106, breathing at 38. He's ill appearing. He has decreased pulses, cool extremities, generalized weakness. And here's his echo. Any thoughts about that? So you can say this mitral valve is like not really getting close to the septum. And then here's our peristernal short axis, also pretty poor squeeze. So here are his labs. His BNP is 22K, creatinine's 3, white count is 20, is 14% bands, CRP is over 300, ferritin 821, fibrinogen, and his COVID RNA is positive. He just had was diagnosed with MIS-C 2 days ago. So any thoughts about this? I can't open this PDF that you just sent, but oh, okay.
Yeah, sorry, no, it was, I just found what he was talking about.
The previous, perfect. Okay, I'll look at it after. All right, so this kid was started on an epi drip. He was given fluids, he was given ceftriaxone and vancomycin. And then here is his, oops. Here is his focused cardiac ultrasound post epi drip. So you see a huge improvement in blood pressure and contractility. And this kid was admitted to the PICU, again, got IVIG and steroids. So I just thought this was really interesting because this was like a MISC bounce back, like he already treated, for this, and then he decompensated again. And I thought it was a really nice pre to post epi demonstration of what we're actually doing and how it's supporting our patients.
Was he treated with IVIG, Julie? It's like he was a bounce back, or?
Yeah. Initially, he got IVIG and steroids, and he was discharged with a prednisone taper.
I mean, it's a great example of using serial echoes to monitor your patient as you're resuscitating them, and knowing what you need to do next, whether it's going to be more pressors or more fluids. I'm curious with the group because I haven't seen it, but have we seen any of the kids who had MISC like last summer come back in with like new exercise intolerance, or have like the 1 year post MISC echoes? Has anybody bumped into one of those patients?
I haven't.
Because this is kind of
exercise intolerance, but
oh, sorry.
I was joking that I personally have exercise intolerance, but that's not new.
We had one kid who had exercise intolerance and a continued, cough and shortness of breath after COVID. This is not answering your question. This is just a tangent. And now several months later was coming in with acutely worsened shortness of breath and chest pain. And he was found to have right RV strain on echo. And everyone was like, oh, this is like clearly like a post-COVID clot. Turned out CTA was negative, and it was pulmonary hypertension. And actually Rahul saw this patient and advocated incredibly fiercely for them. But it was sort of, I think that the pulmonary hypertension might have been going on pre-COVID, and that's sort of like kicked his lungs into, into a downward spiral. But anyway, that doesn't have to do with ultrasound. But I'm going to go on to our next case. All right, so we have an 11-year-old boy presenting with abdominal pain, vomiting, and diarrhea for 5 days. He had a fever to 101. Mom also had watery stools, and they sort of, it's been going on for 5 days, and mom was sick, and they sort of thought it was a viral gastro. At the time of our seeing him, he had normal vitals. He was well appearing. He had some left lower quadrant tenderness on exam, but no rebound, guarding, obturator, or SOA signs. His white count was 9.5. He had a normal BNP. And he was just on his way upstairs for just rehydration for gastroenteritis. And and this was just a sort of an educational scanning shift type of scan, because he was looking really good, no normal white count and everything. The team got an abdominal x-ray that looked like this. Any thoughts about that?
Left lower quadrant gas pattern looks a little funny. Like where all of a sudden shrivels up and pinches off. But that can be any number of things.
It was read as scattered gas, distended, elongated loops of bowel with mild fold thickening and occasional air fluid levels, most suggestive of enteritis. And I thought that was an interesting read. And Antonio Riera has always taught me that enteritis is a diagnosis of exclusion. So that's sort of interesting that, you know, on a radiograph, they were reading that. And so here's the scan. So there's right upper quadrant. There's the liver tip. Sort of a nice reminder to always really get a good view of the liver tip, because you see that is extremely concerning. And then this is what we see in the bowel. So these dilated loops, not peristalsing, sort of a to and fro motion of the bowel contents and free fluid. And I think I would call that a Tanga sign. And then I know the depth is not deep enough here, but here's our transverse view of the pelvis. And then here's our longitudinal view of the pelvis. Do you have any thoughts about this?
I mean, it looks like there's something behind that bladder that's pushing in on it.
Yeah.
So be concerned about whatever that structure is representing.
Right over here.
Yeah.
Julie, what was the presenting complaint or the?
He had 5 days of vomiting and diarrhea. Yeah, so this is concerning, and it looks like there are some hyperechoic parts of this with maybe some shadowing. It's a little tough to say. But Antonio looked at this ultrasound on QPAP, and he was like, that's a perf tappy. So he called the team, and because this kid's like, you know, booked for inpatient and you know, is already like rolling up there. And so he called the team upstairs, and he's like, this kid has a perf tappy, you need to get a radiology ultrasound. So they get one, and it confirms that it's a perf tappy. And then they consult surgery, and I include this note not to do like an us versus them thing, but really just to paint the clinical picture of what was going on. This is the attending's note, that, you know, clinically by story and physical exam, this appears most consistent with the diagnosis of viral gastroenteritis. He's COVID negative. Mom's diarrheal illness supports this. He's not acting like he has pus in his pelvis. You know, he has no evidence of peritonitis. The collection's simple. Maybe it's just proteinaceous debris. I have an extraordinarily low suspicion for appendicitis, but maybe he should get a CT if he really thinks so. And so I just thought it was really interesting because, as you guys know, appendicitis can be so sneaky. And of course, the CAT scan for this patient confirmed appendicitis. So, you know, just keep your eye out and, you know, use your point of care ultrasound, have a high index of suspicion for everyone, and know that enteritis is a diagnosis of exclusion.
I mean, I think one of the major take-home points here for me is that this was a focus done on a educational scanning shift that the clinical team otherwise would not have had a radiology performed ultrasound. And this kid was examined so many times, both in the ER and then afterwards on inpatient. And you know, the report every time was zero pain whatsoever. No pain, no pain, no pain, no pain. So it just lucked out that I came on for an overnight shift and reviewed this ultrasound. There's a little bit of downtime. And so the way it went down was, you know, we had the pediatrics house staff come look at the images with me, examine the patient again at 4 o'clock in the morning. And based on that exam, we opted to just get a radiology ultrasound and not a surgical consult in the middle of the night. Because this child was admitted to the hospitalist service for rehydration, for basically enteritis care, IV fluids and rehydration. And then, so there's always this, to be clear, I didn't look at I think Julie's giving me way too much credit. I didn't look at the ultrasound and say this child is a perfect app yet. I looked at the ultrasound and I said, there's something funky behind the bladder that looks like maybe like a walled off fluid collection. And at one point there's a suggestion of an appendicolith or something where there's either air or like a complete shadow artifact. So that's definitely enough to just follow up with radiology ultrasound for me. And then just given the exam, even the next morning, there was so much skepticism, both the POCUS findings, the radiology ultrasound findings, and he needed the fluid collection to be characterized by CAT scan anyway. But it is just, I think, a really powerful example of how to, I guess, effectively incorporate, scanning shifts into the regular clinical care of ED patients. Because I really think there's a good chance that the exam's okay, tolerate some PO, and he might even be discharged in the morning without the right diagnosis. So anyways, it was a pretty unusual case, obviously, but there's just instances where POCUS is so much, or not just POCUS, but ultrasound, it gives you so much more information where like the history and physical exam becomes so much like a secondary piece of the puzzle, and the ultrasound rises to the top. But anyways, I take up too much time.
Thanks, Antonio.
And
All right.
Antonio, when you sell the movie rights for that, you still have to say that you saw it and said this is a ruptured appy. Stick with that script. But also hats off to the surgeon for actually documenting like medical decision making and thought process. I mean, I haven't seen anything like this in God knows how long. Right? Usually the surgeon's only comment is, what was the CT?
No, right. All right. So our next case is a 17-year-old girl presenting with shortness of breath and near syncope. And that was 3 episodes of near syncope. So she had an ACL repair 3 days ago, and subsequently she's been on aspirin and hydromorphone. She also takes OCPs. And so talking just a little bit more about these presyncopal episodes, she's getting these palpitations, diaphoresis, lightheadedness, nausea, and dizziness while she's seated. It's not like she's standing, like standing up from seated or walking, she's seated and she's having these. And she also has these intermittent sharp pains in her right calf. And she's tried her albuterol and it has not helped. So here's her parasternal long axis. Any thoughts about that?
I want to see the apical 4.
All right. I'm going to show you the parasternal short and the apical 4, and then I want to go back to this one.
Zach wants to see the TR jet.
Okay. Any thoughts about this one? All right, here's our apical 4. Don't have a TR jet.
That's kind of tough, Julie.
Okay. Any thoughts about this one? I think we can agree it's not a plethoric IVC.
Agreed.
Okay. And then we have our TAPSI. Do you guys use TAPSI regularly? Oh, we've talked about this.
I mean, that's technically aberrant, right? Less than 2.
Less than 2, yeah. So less than 2, or even more specifically, less than 1.7. So yeah, this would be concerning for RV strain for sure.
Do you feel like you were seeing where the tricuspid hits the free wall well just in your B mode image though? That was the hard part for me.
Yeah, in this one.
Yeah, I'm not seeing much definition. I don't know.
Right. So this was an EM resident that performed this one, so I don't know I don't know how, and certainly there's variability if you're not getting graded before view, I totally agree. So I just thought it was interesting now that we're sort of like our antennae are up, going into this one, even though it really, like, on first glance, it seems to me like a totally normal parasternal long axis. Does anyone, I'm going to tell you, there's like smile donor melodies. Does anyone? I just thought that this, it's sort of like with the retrospectoscope, you could sort of get a little bit, you start picking at it, but I felt like maybe that septal wall was pushing maybe a little bit, and maybe I'm just reading into it, but certainly in this one, we sort of slow it down. Maybe there's like a glimmer of a D sign, but just so subtle that at bedside, not knowing, what the final diagnosis is, obviously, I feel like that these are really, really subtle findings. Anyway, this girl had a troponin of less than 0.01, BNP of 60, which was normal, D-dimer of 4, and ended up having a CTA, which showed subsegmental pulmonary emboli in the right lower lobe. And she also had a non-occlusive DVT in her right popliteal and posterior tibial veins. So this kid was admitted on a heparin drip, and they held OCPs. And her hypocoagulability workup when I last looked was still pending, but mom has a history of lupus anticoagulant, which is still pending for her. So I thought that was really, really subtle. And I think, now that I feel like we're all seeing more of these PEs, it's sort of nice, it's good to see the variation in how they'll present on ultrasound, and to be more, have our antennae up for maybe more subtle appearances of it.
Was that patient COVID negative, Julie? Just a thought.
What's that?
Was that patient COVID negative?
Yes, they were COVID negative.
So we end up talking about this a lot on image review, which I
Yeah.
do with my adult colleagues, and we look at a lot of cardiac imaging. And there was no way this girl wasn't going to get spun given that history.
Right.
Post-op
Right.
ACL, calf pain, like she was headed to the scanner.
Totally.
But I think that, from looking at the lit and having the discussion with these guys, like, the ultrasound can move the needle a little bit. I don't think it's ever going to rule it out. So
Right.
You got the right history or the right story, you could have a totally normal looking echo. Nothing in the lit speaks to the likelihood ratios really being able to push you like that far without a great history, or rule it out with also the same kind of history.
Yeah, I think we have to remember it's a rule in, not a rule out.
Yeah, and to rule in, when you have all those findings, we're really talking about like giant saddle emboli. And so hopefully that's going to be like a really overwhelming clinical story too. I don't know, for me, I think it's usually the gateway just to like kind of show the fellows or the ultrasound fellows, like all the different other things you can do on the cardiac exam. And I kind of, I'm making a joke with Zach about getting a TR jet, but looking for valve assessments, both of the TR and also the pulmonary outflow, because part of the Vexus paper was looking at that early systolic notching,
right,
with PEs.
Yeah.
And so that gets you into practice and getting that high short axis view and getting a good pulmonary artery view. Yeah, I find these like very frustrating when you have good cases and then you look at the echo and you're expecting so much more, and it's like, oh, I'm really like wishing I could see something abnormal here.
Yeah. All right, this next case, a little bit related. So 17-year-old girl presenting with worsening abdominal and chest pain. This abdominal pain started 5 months ago in the left upper quadrant, and it had resolved. And then last month it recurred again, was worse with running and taking a deep breath. The abdominal ultrasound, blood work, everything was normal. So her pain's worse in terms of the chest pain, it's worse in the left lung field and radiates to her left shoulder. It's another girl that's been on and off OCPs for 3 months for irregular periods. No family history of any kind of clotting disorder. So this is her x-ray, and there's this tiny little rounded opacity at the left costophrenic angle, which was read as possible small pleural effusion in this region. So this is her thoracic ultrasound. So here's our diaphragmatic border, and it's probably the stomach here. And here we see a little effusion and some B lines, some like confluent B lines here. That's like, maybe that's what's going on the x-ray. Then here we see a little bit, here we have this consolidation sort of area in this same place with the linear probe. So we're getting a little bit of a better view of it. So some B lines here, this like shred sign. We're seeing this little effusion again. So what do you guys think about what's going on? Or anything, any thoughts on what might be the next step? Antibiotics, other tests. The fact that I'm asking it and the fact that it's ultrasound conference and probably indicates something else to be done. But anyway, this seemed to the team to be inconsistent with pneumonia, just like the story itself just seemed inconsistent with pneumonia, and they like really had no explanation for this pleural effusion causing this level of pain.
Julie, doesn't it? It sort of seems like the wall of whatever that is like holding its structure more than things that we usually see in the lung. Do you know what I mean? Like,
Interesting.
There's not a lot of like
over here, like it's not like floating around like a lot of.
Yeah, it seems more like rigid or more.
Interesting.
So I don't know what this ends up being, but.
Okay, yeah, no, I really like that observation. So the team ended up getting a D-dimer inflammatory marker as an LDH, and the D-dimer was 2.4, and the CTA showed acute pulmonary emboli in the bilateral lower lobes and right middle lobe, and left basilar consolidations most consistent with pulmonary infarcts. So it sort of goes along with what you were observing, Zach, is that maybe that's what an infarct as opposed to the other pathology we're used to seeing in the lungs looks like. And the cardiology echo demonstrated maintained biventricular function and size, no septal flattening, trivial tricuspid regurg. So sort of exactly what, Adam, what you were saying is that we often just don't have findings on the echo and shouldn't be reassured by a normal echo. But yeah, this was not a typical, infectious consolidation. This was a pulmonary infarct. Any other thoughts about that? So yet another PE. All right, so the next case is a 16-year-old boy with a history of chronic constipation presenting with abdominal pain, diarrhea for 8 days. And today he started vomiting, so he came into the ED. So these were his vitals when he came in. His heart rate was 177, and he was an adult-sized person. He was tachypnic to 24. Otherwise, he wasn't febrile, and he was maintaining his pressures. But he looked pretty awful. He was in moderate distress, pale, diaphoretic, dry mucous membranes. He had decreased breath sounds at both bases and an extremely, extremely distended abdomen with diffuse tenderness, decreased bowel sounds, no rebound or guarding. And his cap refill was a solid 5 seconds. So here's his blood work. So white count of 31,000, 19 bands, BUN and creatinine are bumped. He has a coagulopathy. His lactate is 4. This is his X-ray. So this massively dilated rectosigmoid filled with stool with evidence for large bowel obstruction. And then they wrote, the read said perforation cannot be excluded. So this was called into the ED doc that was taking care of him, and they proceeded with a CAT scan. Now, this was at our community hospital, and what I just told you of the case was done before I got there, and then I came on shift, and the ED doc filled me in as the pediatrician that was on. And so I got the butterfly out. As I told you, that's what we have at the community hospital for now. And while these aren't the greatest, stercoral ulcer. What, Matt, what's a stercoral ulcer?
Basically affect like constipation so bad that you ulcerate out your bowel and rupture it.
Ooh, okay. Yeah, I mean, I like that thought. Yeah, so not my greatest ultrasound images. This is done with the butterfly, but I thought it was pretty striking anyway. This kid, at the time that I got this, he was just white, diaphoretic, tired appearing. He had just had a large bloody stool output and coffee ground emesis. And the plan was to send him by helicopter to the Children's Hospital, and the transport team was on their way already. So this is what I see with the butterfly. He's got this mural thickening and just lack of peristalsis. You can also see here how fast he's breathing. Again, it's an adult-sized person. So he really didn't look good. And then here I go to the bladder to look for free fluid. And I'm like, where is the bladder? Because I swear to you, my probe was midline here. And I only start to see this bladder come into view when I'm sweeping towards the right. And what happened was that the bladder was displaced into the right lower quadrant by the hugely dilated sigmoid colon. And that was what they ended up seeing on CT too. So this is the CT of this hugely distended stool-filled rectum. And the rectum and rectosigmoid junction extend from the pelvis into the upper abdomen. And everything like the diaphragm and the liver are all displaced, like all of his organs are displaced, and which is why my fast was really, really hard to do. But anyway, I thought this case was more remarkable and interesting than necessarily the ultrasound findings. But we ended up deciding this kid was too sick to transport. And so I intubated him in the ED, and we call our surgeon, the same surgeon from the previous, the perf DAPI case. She really is truly an advocate for patients. I really do like her. She called the pediatric surgeon at Greenwich Hospital and said, this kid, isn't safe for transport. You got to do this surgery there. And, so he had a partial colectomy, was stabilized in the MICU, and then sent up to the Yale PICU. His ultimate diagnosis was toxic megacolon. And they really don't have a known underlying cause. Like there's no known, he didn't have a diagnosed Hirschsprung or anything like that. I wonder, Matt, if this stercoral ulcer that you're talking about, if that could be but interestingly, I took a deep dive in his chart, and you can see he has a history of visits to the ED for constipation, and he saw GI starting at age 4. So this has been a lifelong thing. He had a lower endoscopy at age 6, but he wasn't followed by GI any longer. And he was on Miralax daily. And in 2016, he had an abdominal x-ray for, a period of constipation. And they saw this on the x-ray. And I just wonder if, there's, this is just a case of Hirschsprung that wasn't diagnosed. I don't know if anyone has any other thoughts about this. I mean, constipation, really bad.
We've had 1 or 2 of these like 10-year-olds come in as an undiagnosed Hirschsprungs who had even been following a GI for years.
Yeah.
So that's totally within the differential.
Anyway, all right. I am going to, it's 1:48, okay. All right, we have time for 2 more, okay. So we have a 21-year-old girl, 6 weeks postpartum, presenting with epigastric pain. And this woman was diagnosed with reflux throughout her entire pregnancy, like really severe epigastric pain throughout her whole pregnancy that she took Tums for nonstop, but it just never improved. And now it's worsening. She's six weeks postpartum. So I started with a fast. So here's the right upper quadrant view. Anyone see anything of interest?
Little gravel.
Little gravel, yeah, over here, and some crazy shadowing. And then I just to remind you, because I feel like we don't do gallbladder ultrasounds that frequently on the peds side, and the really remarkable ones I've seen have really been on the adult side. But remember, we're looking at like that exclamation point, and then we're looking down to the portal vein, and then looking for that like train track CVD above the portal vein. So this is what we see on the point of care ultrasound. So any thoughts about that?
Double barrel shotgun sign.
Yes. Yeah, it's the double barrel shotgun sign, which I've never seen on the ped side. So this poor postpartum woman had been dealing with severe cholelithiasis her whole pregnancy, and it was only until she was 6 weeks postpartum that it was finally caught. All right, I have one more. We had a 5-year-old boy presenting saying, I think I might have swallowed a magnet. I'm like, did you or didn't you? So he's not sure if he did, and if he did, he's not sure how many. So Matt, I think you'll appreciate this, or you might get PTSD, but this, and it's with the butterfly, so structures in the abdomen are not as crisp, but here's our stomach. And does anyone, yes or no? Anyone? Too small. Yeah, he swallowed the magnet. So, I said to them, yes, you most definitely did swallow it, but I just want to make sure that there's not more than one. So the X-ray confirmed, and it was just one.
Hey, Julie, can you review for us your approach and how you position the patient to try to get the optimal?
Sure.
stomach view?
So I like to do right lateral decubitus so that the stomach contents fall dependently into the gastric antrum. And by doing that, you can, you really expand the gastric antrum so that you have, so that you can, you use that as, you can have your window to see what you need to see. And then essentially epigastric, just subxiphoid. And it's essentially where you would look for the IVC when you're doing the focused cardiac ultrasound. And I'm really looking for the aorta. So, and I'm in longitudinal axis. So antrum, aorta, liver, right lateral decubitus position in longitudinal axis. Anything else to add, Matt?
No, this is really the only thing I've used this for since our projects was to look for foreign bodies.
Yeah, so I think if you're going to look for a foreign body in the stomach, again, you're going to have the most sensitivity if you do right lateral decubitus position and look for the IVC or aorta as a landmark to know that you're over the antrum. Any other thoughts? Thanks for joining. Thanks for all the good discussion.
Do you guys actually look at people's stomachs before you sedate them?
Oh, no.
No.
I've seen what I needed. We were talking about this before. I've seen what I need to see. I know that, if they had a hamburger in the stomach before they fractured their arm, there's probably still some hamburger in the stomach. And, I'm waiting for 8 hours with a painful arm and opiates and, in an anxiety provoking situation, their stomach contents aren't gonna, like, I'm pretty sure there's gonna be some contents in there. So I'm using ketamine, so I'm not, it's a lower risk profile for aspiration. Get some Zofran on board. But yeah, Matt.
Same. I don't, I just assume there's gonna be stuff there. And I think both of our studies, as well as some of the background anesthesia stuff, would bear that out. That you making them weight is sort of foolish. What you have is what you have. It's probably not gonna change all that much. But
Well, thank you, Julie, for presenting. Great discussion, great topics. Hopefully we can follow up that lung study. So hopefully anyone who takes the lead on that. And then just a reminder that we won't be meeting this coming month, and I'll be seeing everyone in September.
Happy birthday, Henry.
Thanks.
Happy birthday. Happy birthday.
Expensive gifts
30
are
30
welcome,
years
by the
old.
way.
Thanks, Julie.
Thanks, everyone.
Thanks,
Great
everyone.
cases, Julie.
Thank you. Thanks for participating.